What's that? That's right, that's right. He's a good friend, so.
Thank you.
Thank you very much. Yes, we are so excited to have Dr. Drabek here today. In today's seminar, we're going to reflect on a deeply human question, and that is, what does it mean to have a good death? We're all going to have one. We might as well figure out how to have a good one. So, our speaker, Dr. Stephen Drabek, he brings more than 35 years in hospice care and over 4 decades in family medicine to this important topic. After surviving esophageal cancer at the age of 30, he devoted his life to helping others find comfort, dignity, and peace at the end of life. He's known as a comfortologist. I learned a new word. Dr. Drabek believes in caring for the whole person, the body, the mind, the spirit. His work in his book, The Comfortologist, what'd you say, available at Barnes & Noble, Amazon, no? Yeah, maybe hit and miss, try it. And it's to remind us that compassion is at the heart of both living well and dying well. So please join me in warmly welcoming Dr. Stephen Drabek.
Only one correction, Marilyn. Insurance companies pay for everything free. If it's free, they cover it. Just saying. And I'm going to talk about a subject, if you think about it, what's it like to be asked to talk about death? And the answer is, I love it. Why? Because traditional medicine doesn't want to talk about it. The worst thing that can happen as a physician is for someone to die. And I did 3 years as the palliative medicine physician at Baptist and at the hospice house. But one day I was called down to the ER, and one of my friends said, "Oh, it's Dr. Death." I looked at him, I had a few words I won't want to mention in public, but I said, "I'm Dr. Pleasant Death." And I stand by that. And at the bottom of this first slide, you'll see the warning. The warning is, sometimes you get me started, it's hard to shut me up. And I love hospice because it's providing something that we really, really need to face early, and that is death. So, first thing is, I want to talk a little just about hospice in general, because there's such a misunderstanding. Oh yeah, hospice. You know, so many doctors, oh, I do hospice. Oh yeah, really? And I've just seen too much of it over the years. When I first started in hospice, there were none in Oklahoma City. And I was part of one of the first two. And I'm proud of that. And I look back in my life, I was molded for this starting at a very young age. But it's a Medicare benefit that it is free. Insurances love hospice. Why do they love hospice? Because we don't embrace medical futility. We don't enjoy doing things to people that won't make a difference. That difference is quality of life. I don't care how long I live, because that's predetermined, my opinion. And that's predetermined by the big guy. So we're all going to face it. We can't define life without death. There's a beginning, there's an end. Hospice to me is just as emotional as birth. Yeah, it's wonderful to have kids. Then they become teenagers. Come on. But people need to talk about it. So in 1983, the federal government, well, not the one today, but the federal government introduced and started the hospice benefit. And it's about making end-of-life care, and really it's about quality of life. Quality of life is not a pulse, it's not breathing, it's about, as I always say, blowing and going with the people you want to be with. People and pets. I'm a dog guy, you'll see later. But it's to provide dignity, quality of life through symptom control and management. When people think about dying, they think about pain. Medical education doesn't train us to treat pain. I've been blessed with chronic pain. Yeah, that's what I said. I've had chronic pain since the mid-90s. Every negative experience somebody with chronic pain has had, I've been through. So the last 5 years, until COVID took me out of an office practice, I was managing chronic pain patients. You meet the nicest people that have had many, many hardships. And so pain is that number one symptom. And it's about consistent control of pain. It's about consistent taking of medications. Don't wait for the pain to get bad. Who won the tortoise and the hare? That darn turtle wins every time. And I learned pain management from hospice nurses. And it's around the clock, giving medications, not waiting for the pain to get worse. Where is hospice? 98% of it is where we want to be. Where would I rather be right now? Well, not right now, Marilyn. But I'd rather be at home. Hospitals. Been there, done that. And not much fun. They serve a vital need in our communities. But there's a lot of things worse than death. You can find them in hospitals. And I've participated in their care. I've been their advocate so many times. And I'm proud of that. And I've helped many people pass through that process of death and dying. My stepmother in 2001, and then my father in 2017. And it's hard. But it's about doing the right thing. It's about helping them be as pain-free, as happy, smiling, enjoying, and where they want to be with the people they want to be with. Now, the thing about family is the word dysfunctional comes to mind very quickly. And I've seen families that I've known for many years, they put the fun in dysfunctional. And that's okay. That's part of it. But helping them work through many difficult issues. Again, 98% of people die at home. So Dorothy from The Wizard of Oz was correct. There's no place like home. So I've seen people in the hospital that all they wanted to do was go home. Traditional medicines, we can't. Had a man with lung cancer, stage 4. His oxygen level, he required so much oxygen, we couldn't provide that at home, only in the hospital. And the pulmonologist is a great guy. I told him one time, I said, you do too good of a job managing patients. And he said, well, this guy can't go home until his oxygen level gets up above 90%. There's no way. And his nurse said, well, what if Dr. Drabek can take him to the hospice house? Well, that'd be okay. So we did. He went over there about 4 o'clock on a Wednesday. Thursday morning he went home to be with his family. And his dogs too. He was a dog guy as well. What's wrong with sending him home? We can't make everything normal when it's failing. Air hunger is a horrible thing. So I learned early on the thing that makes air hunger, even when your oxygen level shows it to be high, is a low dose of morphine. Many people with the drug problem that we hear about in the news, it's not prescription drugs, people. It's illicit drugs. And what do? We can't stop it. But we get people at the end of life, well, I don't want morphine. I don't want to become an addict. I dealt with that with chronic pain patients. My favorite was a 92-year-old woman who took one pill a day of a very mild pain reliever so she could work in her garden or her flower beds. And finally, I said, look, you won't get addicted. And besides, if I catch you downtown Oklahoma City hooking, we'll have to fire you. Took her a minute, but she smiled and she got the joke. But that's the reality of medications. Use them correctly, and you can control pain. You can't eliminate it. A lot of people think it's about eliminating pain. The human body, surgeries, who can make it better than God did? Yeah, it's not going to happen. But it's a tough thing, and I'm alive because of modern medicine, so it's a tough thing. But the first thing you have to do is you have to listen to the patient. What do you want? Where do you want to be? Well, I want to be home. Okay. We'll go home. What? My own father, after he got sick and hospitalized for the first time at 90 years old. And 6 weeks later, he went to an assisted living center. And he started getting the infection in the bloodstream again, what's called sepsis. And I said, Dad, you're starting down that path again. And we need to talk about things. He said, well, I didn't like the hospital. I know. And so he looked at me and he said, well, if that happens again, I have to go to the hospital, don't I? I've been doing hospice 30 years. My dad says that to me, but that's okay. And I said, no, we don't have to. We can keep you comfortable here. After he passed, we all joked about it, my brother and sisters, because he passed on because my stepmother was in heaven. My mother, who died in 1963, was in heaven. And he knew he was going to a better place, and he told me that. So I felt good about it, but it's still difficult. And the hospice nurse that came out for him, it wasn't the hospice I was with because, well, you can't prescribe to family. But she called me and said, what do you want to do? I said, well, wait a minute, you're the nurse. But we did the right thing. We gave him medications routinely because he was miserable. But we joked about it after he had passed because he had all this junk at home. He loved garage sales. And we joked that he knew he couldn't go back home to his junk, so he was ready to move on. That's a defense mechanism for us as family, but it was so true. But hospice is designed to provide all of the equipment to make it easier. That's not easy, but easier to care for your loved one at home. We focus on comfort. We don't want people to go back to the hospital, but they can. If something new comes out that's going to change their terminal diagnosis, that's an option. Most of the time, people don't like to choose that option. But if there's not good communication amongst the family, Cousin Tom comes in from who knows where at the last minute, oh, we're going to save you. We're going to get you on these vitamins and we're going to save you. Well, That's okay, but it's not always the right thing to do. But there's not a right or wrong. So you got to be flexible. You have to be accepting. You have to listen. You have to communicate. We have a team. We have nurses, social workers, chaplains, physicians, intake coordinators, home health aides. So every person that's involved with that patient has the ability to impact their care. They can tell us, they may say to the home health aide, when they're getting a bath, something that's very important to them, and we want them to pass it on to us as physicians and nurses. So it's an interdisciplinary team. Sometimes there's not much discipline there, but we have to joke around. Medical humor can sometimes be strange, to say the least, but it's a defense mechanism as well. But comfort, first thing with comfort is pain. Sleep is difficult. Nothing makes you sleep. Think about it. We've got 100 different commercials on TV that promise us the moon, and nothing makes you sleep. So it's a challenge, but we do sedate them sometimes. If you're lucky, morphine is a sedating medication. Some people, it keeps them awake. But you know, if you've got pain, and your pain is lessened by something, you feel better. So it's a fine line. Physical pain, I'm telling you, that's easier than emotional pain, spiritual pain. But, you know, it's a group effort. And again, communication amongst the team is important. A lack of fear. Who's afraid of death? We all are. We got something to do tomorrow. We don't want death to get in the way. But who makes the final call? Nobody down here does. Death with dignity is becoming more popular across the United States. At least they don't call it physician-assisted suicide anymore. But when it's my time, when I can enjoy life, who can better describe quality of life for me than me? So for me, I wish we had it in Oklahoma. And I have to look at death differently because it's the end of pain. It's the end to suffering. That's what makes me excited about taking care of people at end of life. Spiritual comfort, I've learned a lot from the chaplains over the years. And I call on them and talk to them all the time. So social workers as well. They're counselors when you really think about it. They also know all the magic to get things. People want to be in a safe, comfortable environment, familiar. Pets are important. Half of the people that were reluctant to go to the inpatient hospice unit, when I brought up pets, half of them changed their mind. We had some of the coolest dogs there, and we see the importance of that. I've also learned that making home visits throughout my entire career. It's the little dogs that'll bite you. I've only had one bite me, and that's okay. But the little dogs are going to be right there in the middle of things. So I'd sit on the edge of the bed, talk to the patient. Family would be around the bed sometimes as well. And the dog's right there in the middle. So I never really thought about it, but having a dog treat is a good idea. And I love to make home visits, whether it's medical issues or hospice issues. You can wear comfortable clothing at home, pajamas. Who likes hospital gowns? Nobody. If you've ever been to the Mayo Clinic, they have the most unique gowns. It's a sheet with a hole in it. Holes in the middle. It fits over your head so they can have access from either side. But, you know, medically I understand it. As a patient, man, it's strange. But wearing what's comfortable. So we have self-driven results in hospice. What do you want? Where do you want to be? What do you need? What can we do for you? Volunteers are important as well. Just to be there and sit with folks. And I've done that as well. My highest honor as a physician is when someone hunts me down and says, will you take care of me or will you take care of my loved one? The answer has always been yes. Childhood friend, his father passed, and I still kind of quiet down and think about Earl was his name. And it was an honor. And the first time I saw him, he was part of my practice for a number of years. And then when I left the practice to do hospice full time, hadn't seen him in a few years. And man, he looked like someone from the prison camp. And I was honored to do that. And I was in the middle of a dysfunctional family, not as much fun, but we got through it. And it was a proud moment in my life. So the best way for a team of people to do what they want to do to accomplish everyone's goals, as physicians, nurses, home health aides, we have goals of making that person's life better. It takes time. We get too many people that die within 24 hours sometimes, 1 day, 2 days, 3 days. So it's better to start the process early. Unfortunately, the medical community, it's not their top priority, and I understand that. But when I was in the hospital doing consultations, people would say, well, nobody ever told you how to say no. In my generation, it's changing. We're a little bit more outspoken. This other generation, I don't know how they're going to survive. But our parents said that about us. We did okay most of the time. So being a patient advocate is part of that. Talking to that long-lost cousin who's going to come back at the end and fix everything. You know, I don't like to criticize medicine because I'm alive because of modern medicine. And I've met some phenomenal doctors along the way. At the age of 30, having an esophageal cancer, it's interesting to reflect on it now. But I was never afraid of dying. That's changed over the years a little bit with my other interesting turn of events, but the most interesting thing about the esophageal cancer, it was a result of bad reflux. And I didn't qualify for the Zantac clinical trials. But that's what saved my life. So it's phenomenal to look back. Current total for cancers, for me, 3, because I've been dealing with leukemia for a number of years now. As a result of the treatment for that, which was very well tolerated, except for COVID sneaking in. But it also resulted in a melanoma. So, kind of a wounded warrior, but you just got to keep moving. Try to have a positive attitude. COVID put me in the hospital. I hate hospitals. Ugh. But my biggest fear then was to be a pulmonary cripple. I was on oxygen at night for about a year. But my dog Otis and I, he had a knee surgery in March of 23. I retired from my office practice in June after having COVID in April of 22. That last year was a challenge, but some of us knuckleheads, God has to deliver hard blows. But Otis and I, the first year after I retired from the office, we walked 980 miles. That was my pulmonary rehab and Otis's knee rehab. So it's about having determination to get better. The first 2 years after having esophageal cancer, no word other than hell. They pulled my stomach up into my chest, and it was a challenge. Eating became difficult, and then in 1996 I had an intestinal bleed. They couldn't figure out where it was coming from. But I got 10 units of blood in one day, and the blood was coming from my stomach, which is in the middle of my chest, which is not surgically accessible, in my opinion. There's always a cowboy that's willing to try. But the doctor who was taking care of me never gave up. I owe him my life in many, many, many ways. And so that is a result of that bleed and losing that much blood that gave me a chronic pain syndrome. So God's sense of humor, it's pretty wicked sometimes. But he led me down the path of treating people with chronic pain. And I've been blessed with that. So then COVID came along and I got septic. And my wife, she's weathered all the storms. If she wouldn't have been at my home that April of 2022, I probably would have gone to bed and fallen asleep and not waking up. Which is, by the way, how I want to go. Death, when you think about it, it's always think because we don't talk. But when we think about it, that's how most of us want to do it. There was a story in the Daily Oklahoman a number of years ago about a businessman from Oklahoma who had a place in Colorado. He loved to go there, he loved to fish. And one day he didn't come back from his favorite fishing hole. So his wife called the authorities and they found him inside the river. And so the wife called her son, who went up there to help her, obviously. He knew where Dad's fishing hole was, and he went down. He found his equipment. He picked up the rod. It was a fish on it. One of the nicest trouts. But he died doing something he enjoyed. What more could you ask for? So, thinking about it is one thing, talking about it is another. God, Dad, I don't want to talk about that. That's what my dad said to me. Finally, I said, Dad, I know what you want, I know what you don't want, and I'm willing to fight anybody over that. But do you want me to have to fight them? Well, I guess you're right. So he felt that and remained distracted. So that's a big part of what hospice does. People at the end of life shouldn't be resuscitated, if you think about it. Some people think it's like flipping a switch. It's breaking ribs, it's ventilators. Well, well, you can try to restart it, but don't put me on life support. It's the first thing we did. Put the tube down your throat, we breathe. So it's talking to folks about what that really entails. Okay. Okay, I think that was the next one. It's probably a battery of my life. Okay, medical education, like I said, death is the worst thing that could happen. I'm about pleasant death. Who can find quality of life better than the person you're talking to about quality of life? We sound inevitable. To me, it's an emotional rush in a way to be present at the time someone passes. That's weird. I'm here to tell you. I had a young patient, 22 years old, with a sarcoma, which is the type of cancer that you don't want. It's always bad news. And it's a young black girl. Her mother was a nurse, but no one ever showed them a picture of the CT scan. She couldn't eat. She'd throw everything up. She was in horrible pain. We got her pain control, and I pulled up the CAT scan and I showed it to the mother, and she just broke down in tears. The stomach was pushed way over the abdomen. It was a small air bubble. Normally it's a big air bubble. And that, picture is worth 1,000 words. Why don't we show them? They wouldn't understand it. Yes, they would. If you explain it to them if it's necessary. But this young girl, we got her on a pump that she wore like a Sony Walkman, delivering pain medication constantly, and it had a button she could push if she needed more. She went home for a month or two. She came back on a Sunday. I was leaving for my first vacation in a long time on Thursday. She was unconscious, non-responsive, not eating, not drinking, and the aunt was there and William was working. And I told the aunt, I said, she won't leave here except by celestial discharge. That's what I always call this, celestial discharge. And I told the aunt, I said, I don't see her leaving any other way. And I thought to myself, she won't be here when I get back. She was. And I got home on around midnight on a Thursday. Set up Friday morning, they called, oh, by the way, you need to make rounds at the inpatient unit. Oh, thanks a lot. But I was always happy to do it. Sometimes I would go in there frustrated, angry, whatever. I never, ever, ever left that way. But I saw that she was still there, and I usually made my rounds in clockwise. It's a rationalization, but her room is the last one I went to. I walked in the room, the mother was at the bedside, and I spoke to her a minute. The patient took her last breath and passed. I teared up. I looked at the mother and I said, this is not supposed to happen to me. But she waited. You see some of the most incredible and awesome things at this time in our life. And I'll never forget it. She wanted to be a nurse. She wanted her pain controlled. She wanted to do a few things. And I was glad that I was able to give that to her. Okay, who picks the day that we die? Judy does. Oh, you won't raise your hand? The big guy does. In my book that I wrote, rule number 1, we're all going to die. Rule number 2, God decides. Rule number 3, see rule number 2. And some of the people that have been very resistant to believing that have been preachers. Interesting. They're human. That's my answer to it. Some of the people that choose to take their own lives. Is that wrong? I don't know. I would in a heartbeat if I wasn't enjoying life. We fear most pain, we talked a little bit about. Pain we can manage, the physical pain. Emotional pain, that's a tough one. But emotional pain is real. Anxiety. Everybody gets anxious as they get close to death. It's called terminal restlessness. Witnessing that for the first time, because as a hospice doctor, I'm not at the bedside, except in the inpatient unit, I was, and that's why I loved it. But I had a friend whose mother had terminal restlessness. She'd sit up. Can I lay down? She'd lay down. Can I sit up? And once you settle that down, they pass peacefully. We use Ativan or lorazepam, which is related to Valium. Nowadays, because people that overdose eat medicines like Tic Tacs, they find that in their system. So the medical community has blamed their death on the drugs that they took. Wait a minute, who took them? I've also been blessed to review life insurance claims for the last 20 some odd years. And during the opiate crisis at its peak, I would look at 25 to sometimes 40 deaths a week and medical examiner reports. Then I go home and watch the news. The media kind of blows it out of proportion, but what can you do? So, being present is a blessing. If you're lucky enough, you get to spend those final hours with your loved one. Some of the hardest deaths for me are Alzheimer's. It's a tough disease. It starts with A. Top of the list, I don't want. We don't always get to pick or choose, but anything you can do to help lessen the intensity. Laughter. Sometimes they're sick jokes, but they're funny, especially if they're mine. But, you know, what's wrong with that? You get to know the family, you get to know the person. And in medical school, they told us a story about a teenage boy with leukemia who chose not to suffer any longer. They tried chemo, nothing had worked. And his mother presented to a medical school class. And when he was gone, she was reluctant to go into his bedroom or his closet. Finally, she got the nerve up. She pulled the box down from the closet, and a rubber snake fell. She screamed, she laughed, and then she cried. But she knew he did that intentionally. So laughter is a good thing. Whoever your supreme being is, God, Allah, Buddha, you've got to be non-judgmental. And it's kind of hard for the medical community sometimes, but Sometimes they'll surprise you. Do they have special needs? Are there any regrets? We had a young girl, 32 years old, died from breast cancer. She wanted to go to Destin, Florida, one more time before she died. She wasn't going to be able to. At the time, I was living in a house that had a pool. Guess what? We all came over. She sat on the steps of the pool, and we had the Destiny party. Preachers, mostly it's been dogs at the hospice house, but occasionally I think we had some cats. But some phenomenal animals. As we talked about, no place like home. Dorothy had Toto. Just saying. Deaths occur at home. Usually the hospital bed's in the living room. Why? Because we encourage people to come over. It's less personal as the bedroom. There's usually more room. And besides, my bedroom's junky. My wife can attest to that, but you want a big open space. You want visitors. When my stepmother passed, the preacher from their church came inside the front door, looked around the corner and said, "Oh, Miss Drabek, how are you doing?" What? He's still here. That wasn't his thing. That was okay. But some people got very angry about that. Inpatient hospice, why don't we have more of them? Because it's only for the final hours to days. We can't control the pain at home. We put in subcutaneous lines, kind of like insulin pumps, and we give narcotics, anti-anxiety medicines, sedatives, control their symptoms, and they usually pass peacefully. It's my boy Otis. As everybody knows, all dogs go to heaven. I got a pack waiting on me. I've got Sammy, my golden retriever, Pete, Shepherd Malamute mix, Lola, rat terrorist, as we call her. I had another golden retriever named Dolly, Beauregard the Wonder Dog, who I took to the hospice house. Phenomenal dog, and it just changed the mood of everyone when he was there. So pets are really important. So it's also important if I die before Otis dies. My family knows that Otis needs to see me. Dogs have a better perception of end of life. And there was a movie not too long ago we watched about a dog whose owner died and never saw him. And he traveled all around. It was an incredible movie, but made my eyes leak, as a friend of mine said. But Otis he's incredible. He's an empathetic dog, being through all the things I've been through in the last few years. Okay, unique or unusual needs versus wants. A girl wanted to go to Destin, Florida. We took her virtually, I guess is one way to look at it. Had a friend who, he was a neighbor in Yukon where we live, who had baseballs on the corners of his castle. Because he taught and coached many college athletes in Little League ball. And he was proud of it. He was an incredible guy. Pets present. Do you have to have a formal funeral? I had one friend who chose to have a wake instead. So funerals have always been tough for me. My mother died right before JFK was shot. It was a long time before I realized that was an anniversary reaction, because there's too many times we hear what really happened to JFK. So I heard that every year. She died right before my 7th birthday. And of course, she's probably the reason I'm still alive as well, and why I ended up in medical school. She was a nurse. So you just never know. Corny humor can be helpful. Sometimes sick jokes, depending on the individual, but some wish to be alone, especially men. It's that macho thing, because we're protected of our wives, our daughters, our granddaughters. And many times I would tell families that would just huddle in the inpatient unit, we've got a nice patio. Go out there and get some fresh air. And their loved one might pass while they're out there. And that's okay. Sharing stories. I've got a whole book of stories. Wrote it earlier this year, and if you like stories that have no good explanation about end of life, I'm kind of partial. But what it did more than anything is it reminded me of more stories. That's why I warn people, get me started, it's hard to stop. Sometimes people wait for that special person to arrive. So we've seen that many times. Never was that cousin Tom that's going to make everything okay and change it. But just some of the most amazing things happen in the end-of-life period. How can you encourage people to share their special needs and wants? You've got to talk to them. Medicine nowadays, not much talking goes on these days, but that's what's important, and that's what we do our best to try to accommodate with hospice. Start early. When my dad went into the hospital that final time in his life, they came to take him for a CAT scan. He said, that's radiation. I was part of the Bimini Island experiment. What? My brothers, sisters, and I lived with each other, and that was when he was in the war. Bimini Islands were somewhere around the nuclear testing stuff. Certain barriers need recognition, telling people that it's okay to die. It's very important. Sometimes it's very hard, but it's important. Do not resuscitate orders. Everybody thinks they have to be signed by a doctor or a family member. That form has two sides. The physician caring for the patient can sign it. I've signed many. Because there's guilt associated with signing a do not resuscitate. I encourage everyone on our team to make sure the family is aware that somebody will give the final dose of medicine. And that's not why they died. But it was morphine. You made them more comfortable. They were writhing before you give it. You give them something to reduce the pain and suffering. This is kind of self-explanatory. Just, if you listen to people, they'll tell you. Sometimes they start with what I refer to as "I was born a poet-like child." That was the line from Steve Martin in the joke. They started preconception, I don't know, but trying to get them through is sometimes hard, but sometimes you can't. And it's only time. It's time that you think you don't have, and you may not. but try to be patient. Chaplains are great at that, social workers, nurses. Many of the nurses in hospice now are new to hospice. Why? Some of them got burned out. Some of the best hospice nurses used to be ICU nurses. And they saw many times some of the futile healthcare things that just to keep the pulse. And if you think you figured it all out, there's a zinger coming your way. Okay, try to get to the top priority for that patient who is at the end of life. And it's a journey. To me, it's been a wonderful journey. I've been blessed in so many ways, so many times. The nurses are the workhorse of hospice. The physicians, primarily we listen, we sign prescriptions, and for me to argue with a nurse who wants to give such and such medicine, you just got to be willing to trust them. Some doctors, that's hard. The religious training of chaplains, the social workers, the magic bullets and things that they know and can access. Volunteers usually are people who've lost a loved one who want that experience as well. And bereavement coordinators, hospice isn't done until about a year later. We make ourselves available for family up to a year past the passing of their loved one. Because it ain't over yet. There's anniversary reactions, holidays, first Christmas after death. It's hard. Physician's job is to comfort, guide, and counsel. I'm weird. I'm not the normal. I enjoy it. The comfortologist, that actually was a title that I would halfway joke with some of my chronic pain patients, because it's all about reducing and managing pain and symptoms. Some of the nurses get into what I refer to as fecal fairy tales. They're interesting, but they're not permanent. But constipation is part of every end-of-life journey. Ultimately, God makes the call. Symptoms for comforting pain we've talked about. Nausea. The new medicines for nausea were designed for nausea related to chemotherapy. Zofran, a medicine called Kytril. So we use things more off the typical use of the medication. And you can always learn. I had a patient whose husband was a pharmacist who introduced me to the use of Haldol, which is an antipsychotic, but it does wonders for nausea. Having had nausea more days than not for the last 38 years personally, never experienced it, but I'll never forget it. But it does help people. Weakness and fatigue. The body's kind of drying, downshifting, coming to the end of life. We can't make that much better. Sometimes we get Ritalin or low-dose amphetamines for special occasions. People, as they approach death, they sleep more and more. Who wants to be awake for it? Some do. Restlessness, that terminal restlessness we talked about, it's miserable. It's like insomnia when you can't sleep the night before you go to Disneyland. You're excited. Some creatures fear death are human. accepting death can be a relief for the family. Sometimes you bring it up and they're relieved because they didn't want to. Had a special patient in my practice. His name was Wally Questionably. Wally was an incredible man. If he liked you, he called you an SOB. I went to see him at home as he was dying, and he called me an SOB many times. But then as I was leaving, he said, "Steve, God bless you." It's a non-forgettable moment. Things that aren't supposed to happen. Sarcoma, that was that little girl who waited for me to come back. Had a patient in my practice who came in one day upset. I said, "What's wrong?" "I think I've got a brain tumor." Talked to her, shared with her. So that's a good thing about a computer in your exam room. You go to Google. And I showed her where she took the wrong turn. Now, the odd thing is 5 years later she had lung cancer and brain metastases. But unforgettable moments. Cure sometimes, comfort always. Medicine needs to cure that these days. There's a lot of us with chronic pain and have no interest in addiction. There's nothing fun about taking pain medicines, except I'm in a better mood when my pain's controlled versus not. I don't like who I was. I'm about to get pulled off stage with a giant hook. Frequent challenge with hospice, we get people late. Now, as far as this whole discussion, I quote Dennis Miller a lot. That's just my opinion, I could be wrong. A couple of books. My book is called The Comfortologist. You can get it through Barnes & Noble. It's written similar to a book called When God Winks. A God wink is when something happens. You say, "Why would God do this to me?" And a couple of weeks later, a couple of months later, you figure it out. It's happened to all of us throughout our life. Now, questions? I may not have an answer, but I try. Thank you very much.
All right, does anybody make any questions on your little cards that we can ask Dr. Drabek?
Only easy
Yeah,
questions.
only the easy ones, please.
Hold up your card, somebody come around and get it. All right, here we go. Oh, everybody likes it. Okay. Okay, yay. All right. First question is, how can someone who feels the call to assist the dying get involved as a volunteer?
Call any of the hospices. They all have a volunteer program that's mandated by the Medicare regulations. There's a volunteer training program that they go through. Some people try to volunteer too early after they've lost a loved one. So sometimes they'll talk to you about that, but it's a wonderful thing to do. Taking people to, appointments, sitting with them when the family needs a break is very important as well.
Exactly. I've been a volunteer coordinator for hospice before, and trust me, that phone call that you give them saying you want to volunteer, they will love you. Absolutely. All right. What focus to consider in choosing the right hospice? That's a great question.
If you know someone, hospices should all be the same if they're under federal regulation. That has a different meaning these days. But if they focus on the same rules, it's usually somebody you know. But you can call any of them and get to know them. Somebody that's close to where you live. There's no right or wrong answer to that.
Yeah, and the second part of that question was, does one have to meet certain factors to qualify for hospice?
The main restriction is if you lost a loved one recently, which happens frequently, they're going to counsel you a little bit about that.
But how do you qualify for hospice?
You volunteer.
No, to qualify.
Oh, as a patient.
As a patient, yeah. How does a patient get on hospice?
You have to have a terminal diagnosis that, based on today's medical standards, lead to end of life in 6 months or less. Now, you get recertified. When you first go on, the certification comes right then and then after 90 days. And then every 60 days after that. If you don't die in time, we don't take you off unless... And people get that in their mind and say, well, they didn't die, so we're going to take them off. If that's what the recertification is about, we look at that time 6 months down the line. Every time you look at it, it's 6 months from then.
So theoretically, you could be on hospice for years.
Realistically,
Yeah.
we've got some people that... I was at a hospice meeting yesterday, we had a patient, I think, that was in their 18th benefit period. And the government, at times, will call the hospice on that. And I've gone to a judicial hearing with I forget, some special judge to talk about why we didn't take it on. So medical directors, unfortunately for me, sometimes have to do that. But the person who calls out and says they've got this much time, you have a word for them. Fool. You have to look at all the circumstances. I had a lady that was 103 years old. We didn't put her on hospice for 2 years. She died at 107. Now, when you're 100 and turn 100 on hospice, you get a party. Signed autograph picture of the president. Those are always fun.
All right, here's another question. Does a doctor have to decide on hospice care? Who decides?
Well, there are some doctors that feel like hospice is giving up. And I'm one of the doctors that can make that decision if people call and are interested in their loved one. We send someone out to do an information visit to make sure everybody's on that same page, and the nurse makes the assessment, and then those certifications on initial admission are done by the physician. So, in a way, in a perfect world, the family doctor would refer me, oh, we're not there yet. When people say they're done, listen to them.
Any other questions for Dr. Drabek? Yes, ma'am.
When you go on hospice, do they take all of your medicine away from you?
We only cover the medicines that are related to the terminal illness.
The question was, when you go on hospice, do they take away all your medications?
We oftentimes encourage people to look at their medications, to look at them. Does it make sense to be on a cholesterol-lowering drug at 98, or Alzheimer's disease, high fall risk, and on a blood thinner? Those are some of the things that we look at. And we don't decide, we encourage and we educate the patient and the family.
All righty. Well, thank you, Dr. Drabek. Thank you so much for sharing your knowledge, your compassion, and your expertise with us. We thank you so much. All right, we're going to see all you guys pretty soon. Be sure to go around and check out everybody that's here visiting, and meet your neighbors and meet the new people that came today, and everybody invite somebody to come next time. Thank you very much.